Hello and welcome to ID Talk, Answers from Infectious Diseases Experts. I'm Dr. Nathan Price, a pediatric infectious diseases specialist at Banner University Medical Center, Tucson, and associate professor of pediatrics at the University of Arizona College of Medicine. With Dr. Scott Olson, I'm the Arizona AAP Infectious Disease and Immunization Co-Medical Director. This podcast has been created to answer questions from our chapter members about anything and everything infectious disease and immunization related. Thank you for tuning in today. This is the week of October 6, 2025. So let's get to the questions. The first one is, in Arizona, if a patient tests positive for gonorrhea or chlamydia, does the lab automatically report this to the state, or does the healthcare provider need to report it to the state? Great question. All of the states here in the U.S. have diseases that are reportable, and these lists are based on notifiable conditions either throughout the nation or things that are of local interest. Because of this, each state's list of notifiable diseases is a little bit different. The reason why these diseases are notifiable is because the health department wants to track these things for various reasons. One is to know what's affecting our communities, and other reasons are because they want to be able to help with managing these communicable diseases and to help implement transmission precautions and to help with administration of post-exposure prophylaxis or post-exposure testing. And they can also help advise on what kind of isolation should be implemented depending on the situation. If you go to azdhs.gov, you can see which diseases are reportable here in Arizona. You'll notice that there's two different situations. One is a list of diseases that's reportable by the provider, and another is a list of diseases that's reportable by the laboratory. There's a lot of overlap between the two, but the laboratory list is much more extensive than the list for providers. One of the reasons for this is that healthcare facilities tend to have problems with multi-drug resistant organisms that can be transmitted between patients, and so the health department helps track these and helps implement precautions to prevent spread of these to other people and places. If the disease is on the lab list, the lab will make the report when they get a positive test. But if the disease is also listed on the provider list, the provider should also make a report as well. And the reason for this is that the provider is able to have access to more details that the health department needs in order to better understand the situation and help implement a plan if some sort of intervention is needed. There is a recent update to these lists, and interestingly, gonorrhea is on both the provider and the lab reportable list, but chlamydia is not. Chlamydia is now just on the lab reportable list. In some places, if your institution has an infection prevention team, they may help with reporting to the health department. Now, this highly depends on what kind of resources you have and which disease is involved. For example, diseases that are going to involve special types of isolation and post-exposure prophylaxis in, say, a hospital, that's where your infection prevention team will be much more likely to be involved. But things like gonorrhea and chlamydia, it's pretty unlikely that you'll have enough bandwidth to do any sort of reporting. The timing of when the report should be submitted depends on the disease. Really highly contagious, high-risk diseases are reportable much more quickly than the lower risk situations. Some diseases are reportable within 24 hours, some within 1 working day, and some within 5 working days. So for example, gonorrhea is a 5 working day reportable organism from the provider side. Again, those lists are available and they have all the information that you need as far as knowing which diseases need to be reported and the timeline for that. You can go to the Arizona DHS website to get more information. There are 3 options that you have to report. You can call, you can fax, or you can submit electronically through the MedSys system. To use the MedSys system, you have to have already set it up through your local health department, but you can talk to your liaison on how to get that set up if you haven't done so already. All that information is on the Arizona DHS website. All right, let's go to the next question. Can you review the screening tests for syphilis? Great question. So buckle up. We're going to go through the alphabet soup of what is syphilis testing. And there is a method to the madness, but it can get pretty confusing. And unless you do it over and over again, or you're just really smart, it takes a while to sink in. I had been doing this for quite a while before it really started making sense to me. Okay, so for fun, let's list some of the tests that are out there. There's the RPR, the VDRL, the TPPA, the EIA or CIA. There's the FTA-ABS, the MHA-TP. Those are just naming some of them that are out there. There's other options as well. Basically, the way these tests are set up, there's 2 different situations. One is you're measuring antibody to the inflammatory response in the body caused by syphilis. Those are your non-treponemal tests, the VDRL or the RPR. The others are tests that are measuring responses to the bacterium itself. The bacterium is Treponema pallidum. And those are things like your EIA or your TPPA. So those non-treponemal, the RPR and the VDRL. The RPR stands for the Rapid Plasma Reagent. The VDRL is Venereal Disease Research Lab. They're called non-treponemal because they're measuring antibody to responses like cardiolipin, cholesterol, and lecithin antigens. And they found basically in syphilitic tissue that the body would make those antibodies. And so it correlated well with syphilis disease. The problem with these tests, the RPR and the VDRL, is they can cross-react with other situations. You can see them elevated in certain autoimmune diseases. You can see them elevated in certain viral infections like EBV. And then sometimes even pregnancy can cause someone to have a low false positive RPR or VDRL. They tend to be positive with an elevated titer while someone has active infection, and they tend to wane over time after someone has been treated appropriately with antibiotics, and eventually they become negative, usually in patients after they've been appropriately treated. So when you get a positive RPR, it should reflex to a titer, and you can follow that to see what the response to therapy is. A 1-to-1 titer is the lowest number that you'll see, and the dilutions are set up that it's a doubling in each one. So a 1-to-1 goes to 1-to-2 to 1-to-4 to 1-to-8 and so on. A fourfold change in titer, so 2 dilutions. So for example, a 1-to-2 that goes up to 1-to-4 to 1-to-8, that's fourfold, that's 2 dilutions, that's clinically significant. An increase like that suggests somebody has been reinfected. A fourfold decrease, on the other hand, suggests that somebody has improved after being treated with antibiotics. So a 1-to-8 that goes down to 1-to-2 is a fourfold decrease. 1 dilution up or 1 dilution down may just be lab variability. So if a patient has been appropriately treated and you see the RPR stabilizing going down, but then, oops, it's now increasing by fourfold, that patient has been reinfected and needs to be retreated. When you check these, you pick one and stick with it. So an RPR is followed by an RPR and a VDRL is followed by a VDRL. And that's because the scale is a bit different. It's kind of like Celsius versus Fahrenheit. And so you want to compare the same one, so you're comparing apples to apples when you're looking at that response over time. Interestingly, the RPR is not run on spinal fluid, so you get a VDRL in the spinal fluid, and that's fine because you just want to know is it positive or not in that situation. So if you follow RPRs in the blood, that's fine. If you're worried about CNS disease, you get your lumbar puncture and you look at your VDRL to see if it's positive. In infants that are newborns, we look to see, do they have infection? And one of the ways you can look for that is by getting RPR in the baby, or again, VDRL if you're comparing VDRLs to mom. But what you do is you compare baby's titer to mom's titer. And if the baby's titer is fourfold higher than mom's, then you assume baby has its own infection, is making its own antibody rather than just measuring mom's transplacental antibody that can happen. The important thing to know, though, is that a baby can have syphilis and either have a non-reactive RPR or have an RPR that's not fourfold higher than mom's. The other tests are called treponemal tests because, again, you're measuring antibodies or a reaction against something specific to the bacteria Treponema pallidum. So in that list that I named, the TPPA is the Treponema pallidum particle agglutination test. The EIA and CIA are enzyme immune assays and chemiluminescent assays looking for IgG and IgM to Treponema pallidum. The MHATP is the microhemagglutinin assay for Treponema pallidum, and the FTA-ABS is a fluorescent treponemal antibody absorption test. Once positive, these tend to stay positive for life, although sometimes they can wane over time. Generally, the EIA or CIA or the TPPA are used in labs because they're easier to automate and they have less user variability when it comes to performing the test. It's important to be aware of those other ones because sometimes you get a patient from other places that may do those tests. And so just recognize that those are once positive, always positive tests. For example, I recently had a patient who came from Mexico and they used the MHA-TP test. So diagnosing syphilis can be a little bit tricky. You need to have 2 tests that are positive to confirm because you can have cross-reactivity with certain things. But you also need to know what the clinical situation is because someone may have a positive test from prior infection that's been treated. And so you need to know, have they been treated with antibiotics? What antibiotic were they treated with? When was this? And really importantly, you need to know what the RPR titer response was. So you can track things and see, does it make sense? is the disease over and done with, or have they gotten reinfected, or were they never treated and you need to treat. All this is really important in trying to figure this out. So the classic diagnostic pathway was to use a non-treponemal test like an RPR or a VDRL, and if that was positive, follow it by a treponemal test like the TPPA. If both are positive, then that person has or had syphilis. The newer algorithm is what they call the reverse algorithm. You start with one of those treponemal once positive always tests like the EIA or CIA, and they do that because it's more easily and readily available, followed by an RPR with a titer. In the newborn, we usually just get the non-treponemal, the RPR or the VDRL, and that's because that treponemal test, the EIA or the TPPA, could very well just be mom's, and again, it's a once positive, always positive test. Plus, with the RPR or the VDRL, we can check baby's titers against mom's titers like we talked about before. So let's go through some scenarios, and this will be mostly mom-baby dyads because that's usually the question that I'm getting, but the principles that apply to mom also apply to older children and adults. Okay, so the first scenario is mom has an RPR that's positive, and it's 1 to 16, and it's the time of delivery. Her TPPA is also positive. So we have a non-treponemal that's positive, and we have an RPR that's positive. Two are positive, so this mom either has or has had syphilis. Remember that RPR goes up with infection and then goes down after treatment, and may go up again with reinfection. The TPPA, though, again, once positive, always positive, and may have indicated a prior infection. So we need more information to see what has happened, to see has mom gotten already treated and the RPR is appropriately on the way down, or has she never gotten treatment, or is it on its way up after having gotten treatment? And then the other thing we need to do is see what's going on with baby. And that will involve doing an exam to make sure baby has a normal exam, checking an RPR on the baby and comparing it to mom's. And then if mom is in a high-risk situation for having infection, then we do additional workup and treat accordingly. So in this situation, it turns out that mom has never had testing or treatment for syphilis that she knows of. And so she's got a positive test with the RPR and she's got a positive TPPA. That means she has syphilis and hasn't been treated. So mom needs to be treated for syphilis. During pregnancy, penicillin is the drug of choice. If there's a shortage, then you can give doxycycline if someone isn't pregnant. And since we don't know when mom had infection or when it occurred, we assume that it could be beyond a year. And that's important because if it's beyond a year, you give 3 IM doses of benzathine penicillin a week apart to treat the patient, and then you follow the RPR titer over time to make sure it drops and goes away eventually. In pregnant people and women, it takes about 2 years for it to go all the way down to negative. So because we're worried about exposure in the baby, we're going to do the workup in the baby. And so in this situation, the baby's RPR was 1 to 64. So mom's was 1 to 16, baby's is 1 to 64. So that's 2 dilutions up, that's 4-fold. So that in and of itself says this baby has syphilis. Because mom didn't get any appropriate treatment during pregnancy, it honestly doesn't really matter what the results of baby's workup are. We're still going to treat that baby with 10 days of penicillin. And that's per the AAP Red Book algorithm. And that's because there's a high risk of transmitting disease to the baby. There's a high risk of morbidity and mortality in the baby if you don't diagnose and treat. And babies can be infected and look just fine early on. So in that situation, we'd do a lumbar puncture, we'd do a CBC with diff. I usually get an optho exam, and we do long bone films to see is there any sign and symptom of syphilis. But again, because of the high-risk situation, the baby still would get treated. Okay, let's go to another situation. You have a mom who had an RPR of 1 to 1 early in pregnancy, and her TPPA was positive. Again, we need more information because this could just be the RPR is almost negative because mom's been treated. Well, it turned out in this situation, again, mom had never been tested for syphilis or treated in the past. So this is an infection that mom has. Mom has it during pregnancy, and there's a risk of transmission to the baby. So we're early in pregnancy. Mom can get treated. Since we don't know when she's been treated in the past, then we'll give her 3 doses of IM benzathine penicillin a week apart, and then we will track what her RPR is over time. And then, of course, when baby's born, we'll do an evaluation of the baby as well. So in this situation, what happens is the mom's RPR, next time they check it a few months later, it's negative, and then at time of delivery, the RPR is negative. If you were to check the TPPA again, it would still be positive. Remember, it's once positive, always positive. So there's no need to recheck that. It's really the RPR that we're looking at that situation. And the fact that mom's RPR has stayed negative after treatment suggests that mom has had appropriate treatment. So now that the baby is here, we take a look at the baby. In this case, the baby has a normal exam, but we still need to get an RPR because, again, babies can have normal exams and still have infection. In our case, the baby's RPR is negative. And because mom has been appropriately treated, the baby has a normal exam, the baby's RPR is not fourfold higher than mom, then the chance of syphilis here is less likely. But it's important to recognize that the chance of syphilis is not zero in this baby. You can still have breakthrough infection, even if baby has a negative RPR and looks just fine. So that's why in this scenario, the AAP Red Book says to give an IM dose of benzathine penicillin and follow up the RPR in the baby. Since baby's RPR was negative and the incubation period of syphilis is 3 months, then generally we get an RPR at 3 months of age and make sure it's still negative. If it's positive, then the baby could have had syphilis after all, and we do another workup and potentially treat depending on the situation. All right, let's do another one. Mom had a syphilis EIA, so that's the IgM-IgG that they do. That's, again, it's a treponemal, once positive, always positive test. So she's got a positive EIA early in pregnancy, but her RPR is negative. So if mom had infection, her RPR should be elevated. Now, there's a chance that the RPR is a false negative. There's also a chance that the EIA is a false positive. And one thing that often is done is if one test is positive and the other test is negative, a lot of labs will reflex to do a third test. So, for example, you could reflex and do a TPPA. And in this situation, her TPPA was positive. So she has an EIA that's positive and a TPPA that's positive, but an RPR that's negative. Remember, the two positive tests are the once positive, always positive, and the negative test is the one that goes away with treatment. So, of course, we need more information here. And in this situation, mom had syphilis a few years ago. She got diagnosed and treated appropriately, and after therapy, her RPR went down to negative and has stayed that way. And she goes throughout her whole pregnancy, and on follow-up testing, including at delivery, her RPR stays negative. So this is really a scenario where mom had syphilis before pregnancy. She did not have it during pregnancy, so there's no risk of transmission to the baby. So we don't need to do any evaluation or treatment in the baby. All right, let's do one more. So mom has an EIA that's positive early in pregnancy, and her RPR is 1 to 2. So she's got 2 positive tests. So we assume that she's had syphilis at some point in time. Let's get more information to see what's going on. When you talk to her, she's never had syphilis that she knows of. She did get tested 9 months ago and her RPR was negative. So this is an early infection. Again, that infection within a year, the reason why we care is it helps us determine how much penicillin to give her. So since this is an infection within the last year, she only needs a single dose of benzathine penicillin IM. And of course, we'll follow her RPRs over time. So a few months later, her RPR goes from 1 to 2 down to 1 to 1. They check it again, it's 1 to 1 again. Good, we're on the right track. But at delivery, her RPR is now 1 to 4. So you've gone up 2 levels, or fourfold, right? The 1 to 1 went to 1 to 2, now to 1 to 4. So that's clinically significant, and we assume that mom has been reinfected. So it turns out that her partner was never tested or treated, and this is a pretty common scenario. So this is why we trend those RPRs over time, especially during pregnancy. So since mom got reinfected during pregnancy, there's a really high risk of transmission to the baby. And again, the baby can look normal but still have infection. So it turns out in this baby, the baby has a normal exam. The baby's RPR is 1 to 1. So it's not that automatic you have syphilis because your RPR is fourfold higher. It's less than mom's, and so we don't know one way or another at this point in time. We'll do the full workup on baby. We'll get the CBC with diff, we'll get the lumbar puncture, we'll do the eye exam, we'll do the lung bone x-rays. But again, even if these are all negative, you still treat with 10 days of penicillin because an infection that has not been treated during pregnancy has a high risk of developing disease in the baby, and that baby may be asymptomatic at first and may have a negative RPR even. Since the baby's RPR is detectable, we'll check that at 2, 4, and 6 months after the baby has gotten treated to make sure it goes away and stays away. So that's about all I have for syphilis right now. If you have other questions, feel free to ask them. There's all kinds of different scenarios you can come up with. But really, that AAP Red Book algorithm is very, very helpful with going through the steps of how to diagnose and treat syphilis, especially in pregnancy and in infancy. All right, next question. Can you please review the recommendations for immune-competent individuals for PCV20 or PPSV23? And there was a second related question submitted at the same time as a clarification of using pneumococcal vaccines for patients that are immunocompetent but have chronic conditions like diabetes or cochlear implants. So this is another great question. There are some newer vaccines on the market that have come around the last couple of years, and so there's some newer updates to the recommendations there. One caveat when it comes to vaccines is that the ACIP and the CDC now are starting to make recommendations that may not be evidence-based. So when there's deviation from what should be done, I would highly recommend that you follow the recommendations given by the AAP because those are evidence-based at this time. The good news is that for pneumococcal vaccination, they are in harmony at this point in time, but we'll have to keep track to see if those things change. The pneumococcal vaccines have undergone a lot of iterations over the last couple of years. The earlier one was the PCV7, which covered 7 serotypes. That was followed by the conjugate 13-valent vaccine, and now we have a 15-valent and a 20-valent conjugate vaccine. We also had a polysaccharide vaccine that covered 23 serotypes. And because it was a polysaccharide vaccine, we weren't able to use it in children under the age of 2. And historically, that one has been recommended for children who have higher risk of severe invasive pneumococcal disease. When it comes to using the conjugate vaccines PCV15 or PCV20, there's no preference of one versus the other. But in certain situations, giving an additional dose of 20 or using PPSV23 is recommended, and we'll get to that here in a minute. The polysaccharide vaccine, the PPSV23, is really only recommended for children who have diseases that increase their risk of invasive pneumococcal disease. And there are 2 groups that have increased risk. One is the one that are mostly immunocompetent but have some anatomical issues like CSF leak, and the other have immunocompromising conditions. So that first group, that not particularly immunocompromised otherwise, are children who have CSF leak, who have chronic heart disease, chronic kidney disease, and they exclude maintenance dialysis and nephrotic syndrome because those ones are higher risk, even and go in the immune-compromised group. They have chronic liver disease, chronic lung disease, including moderate persistent or severe persistent asthma, cochlear implant, or diabetes mellitus. When we were using those lower valent pneumococcal conjugate vaccines, so like the 7, the 13, and now even the 15, if you got those vaccines and you were in one of those risk groups, then you would also have a recommendation to get the PPSV23 in addition to the conjugate vaccines. If you had one of the higher risk diseases, so things like lymphoma or asplenia or other acquired or congenital immune deficiencies, it was recommended to get a second dose of the PPSV23 5 years later. And if you're going that route, that's still the recommendation. But now that we have the conjugate vaccine, the 20-valent conjugate vaccine, the PCV20, that can be used in place of the PPSV23. And the upside of using the PCV20 is that you don't need that repeat 5-year PPSV dose that you would have gotten had you used the PPSV in the higher risk group. Now remember, there's no preference of PCV15 versus PCV20. So if you use PCV15 and you have a patient who has one of those higher risk scenarios, then it's recommended you either do the PCV20 or the PPSV23 to give them that extra protection. So for example, if you have a patient with cochlear implants that got the PCV13 series, you'd either give a single dose of the PCV20 or a single dose of the PPSV23. And the same goes if you gave them the full series with the PCV15 and they have something like cochlear implants or CSF leak, you'd either give them a dose of the 20 conjugate vaccine or the PPSV23 polysaccharide vaccine. Okay, that's enough about pneumococcal vaccines. Let's go on to the next question. Please provide a clear guideline on the approach for positive wound, blood, urine, and CSF cultures. Specifically, when are these false positives, which do we repeat, and which do we admit? What are clues for the fastidious organisms? Which preliminary and final blood culture results should we act on, and how aggressive should the approach be? Oh boy, this is a complicated question with a complicated answer, and quite honestly, there's probably too much to go over in just this time. This is something that we could take hours to discuss and is something that all of us struggle with on a regular basis, including infectious disease doctors. But let's unpack this. I'm sure we've all gotten test results back and thought, what do I do with this? The first thing to do is to ask yourself, why did I get the culture in the first place? And this is important because does the patient presentation fit with the disease that is showing up on your culture? Does it make sense? Or could this be a contaminant? And in some places, these areas aren't necessarily sterile, and so you might find a pathogen there that actually isn't causing disease. Any culture system has a risk of contamination, and the percentage depends on which type of culture you're getting and how you're getting it. That being said, there are certain things that you really don't want to call contaminants. For example, I almost never call Staph aureus in the blood or Candida in the blood a contaminant, and that's because these organisms are highly pathogenic and may have mild symptoms at first and can develop into life-threatening diseases quite quickly. Never say never. There is a chance that it could be a contaminant, but if you get one of these, you're not going to blow it off. You're going to work it up, and you're usually going to be treating while you're sorting it out. So let's look at some of these specific cultures and talk about each one in more detail. For wound cultures, the problem is you're sampling the skin usually. And if you're doing a culture outside of the OR, then you're often going to pick up flora in the nearby area. And even if you're getting a specimen in the OR, it can be contaminated by the skin flora. It's even harder to interpret these cultures if the wound has been moist for a while, because then you get a lot of other organisms like Pseudomonas and GI organisms that can get into the mix, in addition to the typical skin organisms like strep and staph. Swabbed cultures from the moist red skin around the G-tube are the bane of my existence because they grow lots of things and they usually aren't clinically relevant. But again, you have to look at the clinical situation and what's going on. So again, look at the context. If you have a cellulitis with an abscess that grows Staph aureus, that really fits the situation. I'm going to tailor my therapy based off of that result. When I see coag-negative staph in a wound culture, that's usually a non-pathogenic organism that's skin flora, and so it's usually not clinically relevant. But there are certain situations where it might be relevant. For example, if somebody has hardware, like back hardware that's eroded through the skin, that can now be colonized and infected with that organism. Or you can see other situations where it may make sense. In those situations, it's really helpful to ask your local ID doctor to help you sort it out. Next, let's talk about urine cultures. These are really problematic because depending on where you are and how it was collected, you can have up to a 40% contamination rate of urine cultures. So we try to mitigate that risk of overcalling something by making sure that we have criteria to help us sort out, is there really an infection here? I recommend that you follow the AAP recommendations in children older than 2 months of age, where they talk about having an abnormal UA paired with an abnormal culture. And then there are colony count differences depending on how the culture was obtained to help, again, screen out that higher risk of contamination. We really shouldn't be culturing from bags because that has a higher risk of getting skin and GI flora because of the area that's in. We really should be getting cultures off of a clean catch or a catheterized specimen in our children. So look at your clinical situation. If you've got greater than 100,000 of an organism that doesn't make sense, especially in a child who doesn't have an abnormal UA, well, then it might be less likely that that's actually an infection. But there are certain situations where it could be an infection. You have to look at your clinical situation. When it's not making sense, I often recommend repeating the UA and repeating the culture to see, is it there multiple times? If it is, then again, you have to look and see, is there something going on in this patient that makes sense, and does it require treatment? Of course, the severity of the presentation will affect whether or not you use empiric therapy while you're waiting on those results. With blood and CSF cultures, the stakes are a lot higher because you have a higher risk of severe morbidity and mortality. So we often have a lower threshold for treating while we're sorting things out. But you still need your clinical context. You've got to see what's going on with the patient. That being said, I've certainly seen serious infections in the bloodstream and the CSF in patients who haven't had fever or who haven't had pleocytosis and have even had a normal white count or a normal CRP. But again, you have to look at the clinical context and sort it out. Blood culture contamination rates vary by institution, but generally the accepted rate is 3%. So that means that you're going to get things that don't make sense from time to time, and you have to sort out, is it a contaminant or is it a real infection? I mentioned earlier that I don't ever blow off Staph aureus and Candida. So those are such bad pathogens, we want to make sure that we're treating and sorting those out. But other things like coag-negative staph, those are non-pathogenic organisms that live on the skin, and if I see that in a blood culture without reason to have that sort of infection, then I usually ignore it. Of course, there are situations where it could be real. People who have central lines in, people who are immune compromised, they have a higher risk of having infections with organisms that aren't typically pathogenic. When you're trying to sort things out and it's not making sense, repeating a culture, especially from a separate site, can really be helpful, because if you have it in both sites, separated especially by time and space, then it's probably a real infection. But you have to be careful there, because every once in a while I get a helpful person who draws two cultures from the same spot and puts it in two separate bottles and calls it a separate site. So if, again, you still get something that doesn't make sense, see if something like that has happened. Contaminants tend to grow a little later than the pathogens do. The pathogens tend to grow within 24 to 48 hours. The contaminants tend to take 3 to 5 days to grow, so sometimes that gives you a little bit of a hint. But usually I'm looking at that for things like coag-negative staph. If I find Staph aureus at 3 to 5 days, I'm still going to work it up as a real infection. In the CSF, anything on the typical pathogen list really should be considered real, and you should be getting more information to sort it out. So if you see an E. coli or group B strep or listeria in a baby, then that's probably the real deal. Same thing with older kids when you see things like pneumococcus and meningococcus. And you can still rarely see that in infants as well. I usually ignore, in an otherwise healthy patient, the skin contaminants, things like micrococcus and coag-negative staph and bacillus species. Because again, they're not generally pathogenic, and if you have an otherwise healthy person, they really have no business having that sort of infection. But of course, you got to look at the clinical context. Does the baby have a neurocutaneous fistula or something like that that could put them at risk for that type of infection? Or is there a VP shunt in place, which tends to get infected with those organisms? So here's a clinical scenario that comes up fairly often. You have a 1-month-old that shows up for a fever workup, and you get your blood cultures, you get your white count, you get your CRP, the baby's doing okay, things look okay, you send them home. And then, oops, 3 days later, the lab calls you back and says they're gram-positive cocci growing in clusters out of the blood culture. Well, when I hear about gram-positive cocci in clusters, the worst-case scenario would be Staph aureus. Remember, we don't want to ignore that. But on the other hand, much more likely is the baby would have a coag-negative staph. So whenever you get one of these calls, the first thing you want to do is ask, is how the baby doing? If the baby's doing fantastic and there's a chance of it being a contaminant, then you might have some time to sit tight. Again, it will depend on what your clinical context is. And if you're lucky, your lab will have one of these systems that does rapid diagnostics. So things that look for PCRs or other things that can tell you, do you have Staph aureus versus coag-negative staph versus something else. So if you have an otherwise healthy baby that doesn't have any musculoskeletal findings, who didn't have any skin findings, who's got gram-positive cocci in clusters, who looks totally fine and sounds totally fine when you talk to the family, and you're going to get your result back on the rapid testing in the next hour or two, you probably can sit tight to make sure that this is not going to be a Staph aureus and likely a coag-negative staph when you get your results back. But if you've got any concern at all and there's any hint of a problem, then you bring that baby back in, you repeat your cultures, you repeat your labs, you repeat your exam, and if you're especially concerned by anything, then you start on empiric therapy while you're waiting for your results to come back. There's all kinds of nuances, and we can go on, but that's probably enough for this for today. If you've got more specific questions, then of course, send them our way. So that does it for today. Thanks for listening. The Arizona AAP members can submit questions for future episodes to id@azaap.org. Arizona AAP would like to acknowledge the generous support of the podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant Funding. For more information and resources related to infectious disease and immunizations in Arizona, or to become a member, please visit azaap.org. Thank you for all that you do, and we'll see you next time at the next ID Talk podcast.